Yes, go.
Okay, so this is an outside consultation that we got. So this is a 56-year-old woman who came in with, pretty non-specific abdominal pain. The only thing that was noted was this lesion that's in the spleen. Um, and on top here, we have the arterial phase, followed by a more delayed, very much delayed phase on the bottom. And what we see is a pretty large, about 4.5 centimeter splenic lesion with central calcifications. And it looks like over time, there's delayed enhancement on the portovenous phase, or sorry, on the delayed phase. And so at that point, we were thinking possibly a hemangioma, recommended an MRI. So these are just some select images from the MRI, which shows a surprisingly T2 dark lesion in the spleen, measuring about 4.3 centimeters there. On the in phase, you can see there's a central focal hypointensity, which corresponds with a calcification. And on the dynamic post-contrast, we see that, there's this kind of radial appearance to the lesion, which enhances progressively over time. So we actually thought that this was a SANT lesion, which I had a review myself, but it's a sclerosing angioedema nodular transformation lesion, which is benign, has no malignant potential, and it has this characteristic T2 hypointense signal, which is due to the hemosiderin, and typically it can have a scar as well, which I think we can see actually in our case. There's kind of a scar there. So I just wanted to show that because I always forget this entity, I feel like.
Yeah, it's a beautiful case. And Gitanjali got it in the chat. But yeah, it's a gorgeous case of it.
Oh, awesome. It's great. And then my next one is a prostate MRI. And there's a very obvious lesion here. We ended up giving this a Pirates category 5. It's got well-subscribed margins. It looks like on the T2, maybe it's got some ECE as well. It looks like it's abutting the lesion is abutting the rectum. It has restricted diffusion and early enhancement. So we gave this a 5. And I wanted to show you this just because it's another thing that I learned about recently, which is the intraductal carcinoma of the prostate, which is a new subtype of prostate cancer that was just recently included in the WHO classification in 2016. It's supposed to be very, very rare and maybe uncommonly found, up to 3% in the presence of the run-of-the-mill adenocarcinoma. And on pathology, is typically located within periurethral ducts. It may show cribriform growth or micropapillary pattern, and it's also tend to have marked nuclear atypia and comedonecrosis. I guess the important thing here to note is that intraductal carcinomas of the prostate, they are associated with a worse clinical outcome compared to traditional adenocarcinoma of a similar Gleason grade. So that was something new that I learned. According to the pathologist I talked to, even if the lesion is like a 3+3 grade 1 lesion, if there's a component of IDC within it, it actually is associated with a worse clinical outcome.
Wow, cool. And there's nothing on imaging that would, like, did you find any imaging articles of like that something would be different about it than a typical prostate cancer?
Not quite. We're actually starting a project to look more closely at these, so hopefully I'll be able to answer you in a few months. But just based on our very rough data collection, it looks like a majority of lesions are larger. They're quite large, and they tend to have pretty low ADC as well. But we're gonna do a more kind of thorough analysis and and see what we get.
Cool. Very cool. Thank you.
You're welcome.
Who else said they had one? Pankaj?
So this is a 47-year-old male who presented for the prostate MRI evaluation for the tumor, raising PSA level. So we can see this is a T2 weighted imaging, and like there is gross hypointensity involving the prostate gland. There is a little bit of wedge-shaped sparing of the right posterolateral kind of like base and the mid zone. Otherwise, the whole prostate looks abnormal. And we see on the diffusion, so like strikingly this diffusion looks more like a ADC, only this area of sparing of the prostate and whole rest of the gland is actually abnormal, showing the diffusion restriction. So these are the ADC image, which shows like diffuse low ADC value, again sparing that right posterolateral base in this 47-year-old male. Any differential or any thought regarding this process?
I know Steve's on. He's our prostate expert.
A thought would be prostatitis potentially.
Mhm. Yeah, so another thing like but that's a good thought because like this was more involving. As a resident, I was thinking whether that spared region is actually an infarct, but like I totally messed up with the ADC and diffusion. And then further on further evaluation, we can see very prominent lymph nodes. And now we can see like this external kind of the lymph nodes along the external chain, inguinal region, and more proximally there were nodes in the
About lymphoma.
yeah. So this patient was known for Burkitt's lymphoma, and the biopsy resulted in the lymphoma infiltration of the prostate gland.
Great case.
Wow. Are the bones also involved?
Yeah, those
Like
like
some
bone were,
neuroabnormalities.
yeah, we suspected for the bone, but we haven't got the report for the bone biopsy yet.
Cool. This is more prostate cases than we've seen in a long time.
Yeah, so like there was a review, like I was involved in the review paper for the non-epithelial neoplasm of the prostate. So the primary prostate lymphoma is exceedingly rare, only kind of like less than 100 cases were reported. So generally bulky lymphadenopathy along the external iliac chain, common iliac chain, and the prostate involvement is a common, and the age, especially the age of the patient, is younger than the for the primary epithelial cancer age group.
Cool. Thank you.
Thank you.
Anyone else? I have a couple. Oops. Okay. So this is my first one. Tell me what you guys think.
Lots of abnormal bowel.
Yes, exactly. So there is edematous jejunum. You can see submucosal edema, kind of hyperenhancement, some stranding surrounding the jejunum. So we thought there was a sort of diffuse enteritis. The patient did not have any history of inflammatory bowel disease. Their vessels were widely patent.
Antihypertensive.
Yes, they're hypertensive.
So
what do you think?
ACE inhibitors.
Yes, exactly. This was ACE inhibitor angioedema. So that is one of the forms of angioedema, which could be from ACE inhibitors or can be from a congenital abnormality where you're missing this ACE enzyme. And it usually affects the small bowel and particularly the jejunum, but it can affect the colon too. In this case, the rectum was also thickened, so we thought it was also involving the rectum. It's kind of, there's nothing else that's specific about it versus other enteritises, but if you look in the chart and the patient's on ACE inhibitor, that's something you can bring up. Okay, this is my next one. So you can see that there's severe biliary dilation, also some pancreatic ductal dilation. and just this very large mass at the ampulla. So it was a large tubulovillous adenoma, just kind of a really nice example of it. And in this case, causing biliary obstruction. So when you have these TVAs, you can get them anywhere in the GI tract, including the colon. They have a higher rate of malignancy than other types of adenomas. I think in the colon, the rate of malignancy is about 10%, but I think it's a higher rate when it's in the duodenum. And if you have a smaller TVA, they can do like piecemeal resection endoscopically, but this one, they're going to have to do a Whipple. So any malignant tumor involving the ampulla, usually they have to do a Whipple. Okay, this is my next case. What do you guys think about this HSG?
Is there like venous reflux or?
Good thought. It was not venous reflux.
Sometimes you can get a case that's adenomyosis, where the glands fill irregularly.
Yeah,
Oh,
that's what
yeah.
this was. So I'd never seen anything like this. My colleague was just showing us this the other day. So this was actually severe adenomyosis with, so adenomyosis is when the endometrial tissue invades into the myometrium. And I guess like it's communicating. I was usually on MR and stuff, we see like cystic change in the myometrium. But in this case, I guess the endometrium is completely communicating with it. I do have the MRI correlate for this patient. So this is a nice example of adenomyosis. And actually at SABI, Susan Asher recently gave a talk about adenomyosis. And one thing that I learned was that it's unreliable to use the junctional zone width thickness in premenopausal patients. So I had learned that, you can use 12 millimeters, but apparently that's not, they done now like a extensive study with path proof, and that's not reliable in premenopausal patients. In postmenopausal patients, it is reliable. So you can still use 12 millimeters. In premenopausal, you have to look for these cystic changes and then also irregularity of the border of the junctional zone. So in this case, I mean, the junctional zone is markedly thickened. There's all these cystic spaces here. So it's clearer, but if it's just mildly thickened and it's like, 12 or more in a premenopausal patient, don't use that number. And Pankaj is saying adenomyosis. So this is adenomyosis, which is a shorter word like uterus, and adenomyosis is a longer word like gallbladder. So completely different process in the gallbladder. Any comments on the thickness thing?
That's a great tip to remember it though.
Oh, thanks. Okay, and then this is my last case. This patient came in with right lower quadrant pain. And we were looking for their appendix, and on this, T2 fat sat, this is actually the appendix here. And just want to point out, it doesn't really look edematous. But
That was for appendicitis.
uh-huh. This was the diffusion. And you can see that it's actually restricting this little tubular thing here. And on the ADC, it's actually quite dark. So anyway, this was, they went in and removed this appendix, and it was appendicitis. So this was a great call by my colleague Melina, and she basically saw it on the diffusion, even though it wasn't lighting up on the spare. So just a tip, if you're looking for appendicitis on MR, also check out the diffusion.
I love the diffusion. It saved me so many times.
For have you used it for appendicitis? Or just in
No,
general?
not just in general.
Oh, cool.
It's actually great in when we do MREs to look for inflammation, at least to prove that you're right when you're calling something abnormal on the post contrast. So it's specific. It's specific, yeah. Not always very sensitive, but it can be quite specific.
Cool.
Can you
Nelly,
see my
wanna go?
screen?
Yep.
Okay, great. This is a patient who has a history of, well, what do you guys think? This is, what do you guys think about the
Like
liver?
a lot of abnormal perfusion of the liver.
Yeah, and what, like, with what kind of, what would you think about leading to this abnormal perfusion of liver?
Budd Chiari.
Budd Chiari, yeah. So this patient has a history of like she has a blood disorder of some sort and started developing clots when she was young, and developed Budd Chiari. That patient's now on the transplant list for this condition, and we got a pre-transplant. And let me, I can show you.
Can you show
so-
the hepatic veins or when you go back to the CT?
Oh yeah, let me go back to the hepatic veins. Here's the venous. So you can see the middle, and then the left, the right, I don't see very well here. Here it looks like it's thrombosed. And then where it's occluded is at the confluence up here. And then we can see that that was confirmed angiographically. So they did a transhepatic access, and there's all of this collateral formation that drains into the thoracic, like the internal mammary veins, which I can show you on the CT, but there's no return to the IVC because of occlusion at the common, sort of the confluence. So here, this is where you can, this is where the venous drainage is through the sort of recanalized umbilical vein here that drains into the umbilicus, and then also venous collaterals going cranially, and that drains to the internal mammary. But I'm showing this case not for that. I'm showing this case for the liver lesion findings.
Nelly, I have a question about the angio. Like, what did they
yeah.
do for this patient?
They were trying to recanalize her, tried to open up the IVC and trying to do, and they couldn't access it. They couldn't get access. So they aborted the procedure.
Got it. I know sometimes in acute Budd Chiari, sometimes they'll also do a TIPS. Because
yeah,
they
sorry,
want
that's what they
to-
were trying to do, TIPS. But it was
Okay.
they couldn't. The middle hepatic vein was completely occluded, and so they couldn't gain access to the IVC.
Got it.
So they weren't able to do the TIPS, unfortunately.
Yeah, because sometimes like the acute congestion can really hurt the liver, so they're just trying to open it up. And Kedar is writing into the chat nodular hyperplasia.
Yes, that's right. That's so right. There's all these. So I'm showing this case because of the liver lesions. So there's all these little small enhancing liver lesions throughout the abdomen, liver, excuse me, here, and on the venous phase, they're ISO. They don't really wash out. And then here's a 5-minute delay. They don't really wash out. So yes, I'm showing this case exactly for that. Let me.
Nelly, I was just in Arkansas yesterday and I showed it the exact same thing. And
are you serious?
yeah, and we were
Oh my
talking about
God.
it with Kedar. And
Great
Gitanjali
minds
and
think
Rupa.
alike. Great minds think alike. So let me see. Sorry, I had my OneNote up and then I messed it up. See if I can bring it back to life.
I
Can
can
you
see
see
your
my screen?
yeah, I can see your this case report you're showing.
Yeah, so that you can get these FNH-like lesions in patients with Budd Chiari. And this case report was interesting because they showed how with EVIS you can get this central sign, or it's like a, let me see if I can, when you give EVIS, you can get like central washout and this enhancement along the periphery, which I hadn't really known about. I wonder if I can zoom into this thing.
That's interesting because you can see that in FNHs too, because the central scar sometimes is, because it's a scar, it doesn't have the OATP receptors.
Oh,
So
okay.
these also have a central scar.
I don't know about that central scar here, but the case report described this central washout. And then you have EOVIS uptake into the periphery, which is seen in FNH-like lesions. That was cool. I didn't know that.
Yeah, I think it must, like, since they're FNH-like, maybe it is the central scar thing, which is usually like FNH is a proliferation of hepatocytes in reaction to a vascular abnormality. So that vascular abnormality is usually in the center, like in the scar.
Oh, gotcha.
Cool. Does anyone else have cases? Nelly, do you have any more?
Hey, Aarti, can I show one case more to ask an opinion what everybody thinks? You've seen this case. You share my screen. Can everyone see my screen?
Yeah.
Yeah.
So this is a 31-year-old lady who has had history of pancreatitis since she was 16. And so this is her T2. She's had a stent placed before, ERCP stent, and she's back with elevated bilirubin. And there was an outside study, which I don't have, which showed, you know, a dilated pancreatic duct, dilated CBD. They didn't see this for some reason, but there is this stone, sludge, something there. And then what's really interesting is that she has this hyperintense lesion in the region of the pancreatic head, and it restricts intensely on the ADC map. And then following, these are the post-contrast images, and really there is minimal, if any, enhancement. This is subtraction. And these are T2-weighted. And the new history that I got, the new labs, is that her CA19-9 is 20,000. And I really have no clue what this is. So I wanted to see if anybody from the group had any thoughts about what this could be. And she's 31.
I have a new question. So if she's been having pancreatitis since she was 16, I feel like if this mass was the cause of her pancreatitis, we would have seen it on prior imaging.
So it's been reported on previous imaging, but that imaging is just from like 6 months or 6 months old. It's not, we don't have anything older than that, but that's from her history.
The fact that it's T1 bright and potentially doesn't enhance makes you think it's like a hemorrhagic or proteinaceous filled space.
So is that something that can cause this obstruction, or these are two totally different?
Well, pseudocysts can be under pressure enough to block ducts. Any fluid collection under pressure enough could block a duct, I guess.
So I mean, she's supposed
Does she
to
have
get
normal?
I'm sorry.
Does she have normal anatomy? Like, does she have any like a variant drainage or?
Well, not really. We were just concerned about the way the CBD is. You know, it's huge, and almost like a choledochal cyst.
Yeah, like the type 3, the diverticulum.
So I mean, I couldn't even really trace the the CBD well to say which is the CBD, and if that's a diverticulum or.
And the intrahepatic ducts kind of look weird too. Like
I was just thinking that too. It looks
like
almost like kind of beaded. Like maybe it's in the
appearance
spectrum of like Caroli's or something.
Yeah. And sorry, it could it be a stone? Sorry, did we rule a stone out?
You mean could this be a stone?
Yeah. Do we have CT? Like, is it dense?
Well, there was an outside CT, so we don't have that yet. I'll try and get a follow-up once I get the CT, but I just really wasn't sure what to make of this thing. So I wanted to see if anybody's seen anything like this before.
Yeah, my first thought was also like Steve, a hematoma, but it looked, I saw this yesterday in Arkansas, and it looked like there was actually some low level enhancement in it. And even on the subtractions, there was some low level enhancement. So then I just didn't feel like we could just call it a hematoma.
Okay.
But I do agree that if it was a hematoma, it could definitely, I think it could obstruct the ducts. But those ducts are just so weird. I don't know. I feel like she has some kind of diffuse biliary abnormality.
Okay, I should get a follow-up on this one, because again, can't explain the CA 19.9 of 20,000.
Yeah, I mean,
Nothing explains that.
ERCP with EUS.
Yeah, which is what is going to be done tomorrow. So I should have a follow-up. It just looked like an interesting.
Let us know.
Yep, for sure. Thanks.
Okay, this is a patient CT. Came with abdominal pain, a little bit of inflammation here around the diverticulum, but there's something else too. What do you guys think?
Big cystic mass in the pelvis.
Mm-hmm. Yeah, yeah.
Is it a male
Okay.
or female?
A woman.
And where's the uterus?
Does she
Is that
have
the
a
ovary?
uterus, or this is at the uterus?
The patient had a hysterectomy.
Oh.
Here's the.
Could be one of her ovaries.
Yeah, agreed. So we can trace it to the, probably to the left next.
Is it a torsed, massive
Right
torsed
there.
ovary?
That's a good thought, but she would have to be symptomatic. I don't know why she's got two diagnoses. Unless it was a
Six months victim.
misproportioned ovary.
Okay. Okay, good. What else? What else do we see on the images?
Was there some fat in it?
Was there some fat in it? I didn't see any fat. Did I miss it?
No, as you're scrolling through, I thought I spotted it maybe, but
Okay, what else?
it was just, I think that's just artifact from the bones.
Yes, agreed.
Is there a mucocele too?
Yeah, right.
So like a metastasis from.
Yeah,
No way.
right there. There's your mucocele.
Right. But you're like that mucocele, I feel can't metastasize to that ovary like that.
Can it? Or cannot? Okay, so I'm going to, I didn't know this, but it can. And apparently it has to do with the nomenclature. So this patient had all this resected and had low-grade appendiceal mucinous neoplasm, LAMN. And let's see. Can you see my images or report?
Yes.
Okay, good. All right, so it had LAMN, and then the mucinous, the adnexa, they classified it as metastasis, and it has to do with some kind of nomenclature now that changed apparently. Oh man. So I'm gonna just read it to you and share my screen because I don't want to risk. See the, okay, so basically they said that there was a change in the nomenclature, and it says the current medical convention dictates that in the setting of ovarian mucinous lesion and an unequivocal appendiceal lesion, which this patient has, the peritoneal and the ovarian tumors are to be considered metastasis from the appendix, LAMN primary. So that's the new nomenclature. So they said, histologically, we cannot definitively exclude the possibility of two synchronous or metachronous primary process, i.e. an appendiceal LAMN and a mucinous borderline tumor of the ovaries. And immunochemistry is not helpful in this particular scenario. And then what I said to you, which is that the current medical convention dictates that in the setting of ovarian mucinous lesion and an unequivocal appendiceal lesion, the ovarian is considered metastasis from the appendix. I didn't know that.
Yes, I didn't know that either. And I would have.
I lost you.
Yeah, me too.
Oh, can you hear me now?
Yes.
I would have thought they were two separate primaries because usually when lamin metastasizes, it perforates and it causes, like mucinous.
Pseudomyxoma.
Yeah. But and then I would have thought it could land on the ovary, but I haven't seen it, especially low grade. Usually it doesn't like actually metastasize unless it's like it perforates and then it spreads onto other organs, but it doesn't actually like cause, like a hematogenous or lymphatic metastasis. So anyway, that's really interesting.
Yeah.
I wonder why they changed that. If they say they still can't exclude that they're not two primaries, but I guess maybe they're saying there's some way that the appendiceal one has a route to metastasize to the ovary. That's like a known pathway. And therefore, if you see both together, then it must be the met, or it's more likely to be a met.
Yeah. Well, I'm sure a bunch of enthusiastic pathologists got together and discussed all of this. And
Not sure if that changes my life as a radiologist.
It's cool. Thank you.
Yeah. Okay. Here's my other case. So this patient, oh yes. So tell me about this patient. So one of the kidneys is gone on the left. Okay. What else?
That's
Anything else?
cyst.
Yeah. I'm sorry. What did you say? Neurovascular. What?
Is that a seminal vesicle cyst?
Yes. Yes.
Zinner syndrome.
Yes. Yes. That's right. So here is the T2. And it shows and it didn't have any enhancement. So there's your seminal vesicle syndrome. And yes, this is a great example of Zinner syndrome. So patients with Zinner syndrome have a genesis, renal agenesis with an ipsilateral congenital seminal vesicle cyst. And this is the male equivalent of the women MRKH syndrome. I think we've shown cases of MRKH syndrome where the women they don't have a uterus, but they have normal ovaries. So this is the male equivalent. Can you guys still hear me?
Yes.
Okay, you just got quiet.
I was just trying to figure out how it's the male equivalent because MRKH is like complete agenesis, and this is a cyst. But it must be something to do with like the Mullerian. I don't know. I can't figure out how it's the male equivalent, but I take your word for it.
Oh, that's what I read from the paper. So I just trust whatever they wrote because they know more about this than I do. Okay, this next case is, let me get the case. A case from one of our fellows, Matt Harwood. I think, is he on? I thought I saw his name. I don't know if he's logged off since, but so this is a case he shared with us, a really cool case. It's loading. Okay. The patient has had abdominal pain. And the arrow sign points you to the
vasculitis to the splanchnic vessels.
Yeah, well, so there's a complete occlusion of the SMA right there. And there's all this stranding around it. Oh, here, there's more of it here, right there.
Wow, it looks really severe, but like his bowel doesn't look bad.
Yeah, it's not, yeah, exactly. It doesn't look ischemic yet.
Collateral.
So what?
Collateral flow for now.
Oh, right. So any thoughts as to what this is? So this patient has congenital bicuspid aortic valves, and then had aortic vegetation. So that's septic thrombus, and there's a pseudoaneurysm here coming off the aortic root.
Wow, that also looks scary.
Yeah. Super scary.
I haven't seen an embolus to the SMA since I was a resident.
Nelly, do you know what they will do for both that aneurysm and the?
I think they surgically treated it, or like the cardiac, and then I'm not sure what the follow-up was. I have to look it up. Sorry.
No worries.
We have 11:40. Does anybody have more cases or no? If not, I can keep showing.
Yeah, keep going. If anybody else has cases, type into the chat and we'll.
Okay. So this next patient had a renal lesion that we've been surveying, and the patient was being just routinely surveyed, and I read the follow-up exam, and I thought that was interesting because it was a companion case to a previously presented case of what I think this is. So the study that I read was this. It was a follow-up exam, like I mentioned. So there's a non-con arterial, I think it was a urogram protocol. And the lesion that we were looking at was this lesion here. Here's our, here. Right there. And let me give you, we have a 10-minute excretory. Any thoughts from anybody?
Yeah, my thoughts are, what's the idea for surveillance here?
Oh, what do you mean, what's the idea for surveillance?
Well, because what you're showing us looks like
Yeah, tell me, what does it look like?
it looks like a lesion that could be operated upon because it has a differential that includes RCC.
Okay, I'll just say, sorry, did somebody say something? Oh man, where's my current? Sorry here. So
It was an MRI and it fails the, what is it? The MR clear cell score.
Okay, well, here's the MRI.
Clear cell likelihood score.
Does it fail it? I don't know. I
think it would actually meet it because it's T2 bright. It's got heterogeneous enhancement. And I don't know if Nelly, you were trying, it looks like there's some nodular enhancements. I don't know if you're kind of thinking about a hemangioma.
That's what I was thinking about. Well, of course, it could certainly be a clear cell. I feel like clear cell can look like anything and everything, and always needs to be on the diff. Because it's the most common thing, and I mean, I've certainly been fooled by lesions that I thought was papillary and turned out to be clear cell. And so this will be continually surveyed, but the T2 looks really bright to me. Is it not super bright for clear cell, or is that expected? And there's like this nodular enhancement that fills in, or do you guys feel pretty confident this is like clear cell?
I would like to see some, vascular looking calcifications maybe on the non.
Yeah, phleboliths. It doesn't have phleboliths, unfortunately, which would have helped so much. But
is it growing, Nelly?
It is growing. Yeah.
I'm not sure you can rule out renal cancer. I mean, you just
I feel like
agreed.
Hemangioma and pass it.
Agreed. Absolutely agreed. Yeah, I don't think this is diagnostic without a diff. So keep going. What else?
No,
what were you gonna say, Aarti?
No. I feel like you have to say because hemangioma is also so rare. I do think clear cells can be this T2 bright. So I think that, clear cell has to.
Yeah, I agree. And that's like the one take home message is like clear cell. I'm a lot more generous about including clear cell, even if it has typical appearance of non-clear cell. So, okay, great. This other case was here. So this patient has history of bladder cancer, has cystectomy like conduit, and we've been kind of just following him with non-con in the past because of his CKD and solitary kidney. So this was one of the follow-ups, and I think it was a super subtle finding that kind of became less apparent over time. So then we have, so that was the first one, and then we had a follow-up. I know that is it. And then there was an NED on non-con, right? And like non-con is so limited. And then, this was another fault. Oh man, now there's arrow sign. Bummer, but anyways, that's okay. Still good learning points here. See if I can. So on this study, the pancreas started to look a little off.
Looks like there's a dilated duct in the tail and maybe a cutoff sign.
Yeah, and so then the patient went on to get a contrast enhanced exam. And this one came back, yeah, as pancreatic ductal adenocarcinoma that was hiding this whole time because we had all these non-cons. And it was just really hard to pick up until it became kind of apparent by non-con imaging. But if we had contrast enhanced, then it would have been probably picked up earlier.
When I look at non-contrasted imaging and I go through the checklist of organs, that's one of the things that I try hard to look at on
is that right?
contrasted pancreas is, can I see the duct or not? And if so, does it look abnormal, ectatic, cutoff signs? I've seen them before like this. And so
scary.
Yeah, you don't want to get burned. So look for the duct even on an uncon.
Huh. It's a good way. I'll add that to my checklist.
Yeah, I think this is a really good teaching point because I have seen pancreas stuff missed on non-cons. So I feel like we just kind of don't look at it as carefully because we think that we are not going to be able to see anything.
Yeah.
It's a really good point.
So, okay, this next case is another GU case. Okay. So this is a patient with a renal lesion right there. And we don't really have MR on this case, but the patient, I'm showing this case to you because of what the pathology showed. So the pathology said papillary renal cell carcinoma with focal clear cell features. I was like, what? So I didn't realize you can have, I didn't know you can have focal clear cell features in papillary. And this patient had type 2 papillary, which is the more aggressive subtype. And I'm showing this because I found out that you can have all these kind of combo lesions. So here's a example of a patient who has a clear cell papillary renal cell carcinoma, and that's a separate entity from clear cell and separate from papillary by immunohistochemistry. So it's kind of like, what does it remind me of? It's like the hepatical, like the biphenotypic HCC cholangio, right? It's like a separate histology together, even though there's kind of a mix of both. And so, it gets more complex than we think by pathology. But this patient had type 2, which is the more aggressive. So we're just very careful to monitor this patient closely because type 2 papillary can be very aggressive, even if they're small. Okay. Any thoughts or questions about that?
No, that's cool. I've seen that on Path before, like where they say papillary with clear cell features, but I didn't know that there was this combo lesion.
Yeah, and it's a distinct histology. So, okay, I'll leave it there and save my cases for next week.
You were on a roll. There's a lot of cases.
I know I missed last week, so I've got a lot of cases to share.
Cool. Anyone else have cases? Or we will end. Okay, have a great day, everyone.
Thanks all.